السلام عليكم. الو. دكتور عزت هنبدا نحن ان شاء الله. يلا بسم الله. بسم الله والصلاه والسلام على رسول الله وعلى اله وصحبه ومن والاه. Dear all respective speakers and attendees, welcome to our webinar today. Allow me to introduce our moderator today, Dr. Izzat Al-Fouli. He is the head of department of orthopedic department in SGH Medina. تفضل دكتور عزت.
السلام عليكم ورحمة الله وبركاته. Today we will start with SGH Medina. This webinar will be on cervical spine injuries, importance and update. Speakers will be the first one is they are the main stones of the spine unit in SGH Medina Orthopedic Department. First of all, I want to talk about Orthopedic Department in SGH Medina. Orthopedic Department in SGH Medina is one of the biggest department in SGH group. It has many units. It has one of the biggest unit department is the spine unit. There is also a hand surgery unit. There is also pediatric unit. There is also arthroplasty unit, arthroscopy unit, Elizarov unit. This webinar will be the first webinar for the department, and it will not be the last. Now we will start the webinar, and now we will start with Dr. Muhammad Hablas. Dr. Muhammad Hablas is a consultant of orthopedic surgery and spine surgery. He is one of the pioneers in this specialty. He will present about C1, C2 instability injuries. So now we, Dr. Muhammad, please start.
السلام عليكم ورحمة الله وبركاته. سعيد إن أبقى معاكم. I'm very glad to be here today with you all. I have this nice presentation. I hope you all enjoy. It's about C1, C2 rotational instability. Shall I start, sir? بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. We have today a lecture about post-traumatic C1, C2 rotational instability. I'm Dr. Muhammad Hablas. I'm an orthopedic and spine consultant, MD in Shams University. I work at Saudi German Hospital, Medina. Definition. Rotational instability or rotational subluxation or dislocation of C1 on C2. Epidemiology. Trauma has caused up to 24% among C1, C2 instabilities. It's a rare complication leading to pain, spinal cord injury, or death. It's often misdiagnosed on the initial radiographs. Clinical and radiological diagnosis is difficult. The delay to diagnosis and treatment reported as a negative prognostic factor with poor outcome. Atlantoaxial instability is seen in up to 30% of patients with Down syndrome, but only 1% of patients are symptomatic. Patients with rheumatoid arthritis are susceptible to C1, C2 instability ranges of 25% to 80%. Other diseases, including golden hair syndrome, Morquis syndrome, spondyloepiphyseal dysplasia, have C1, C2 instability. I mention these diseases because if you have a patient trauma with any of these symptoms, look for them. Anatomy of C1. It's formed of anterior arch, posterior arch, lateral masses, vertebral foramen, transverse process. Anatomy of C2 is formed of dens, pedicles, laminae, spinous process, and body. C1, C2 ligaments. There is two important ligaments. If you see the photo, the yellow one and the blue one. The yellow one, the transverse ligament, connects the lateral mass of atlas and fixes the dens in place. Ligament restricts flexion as well as anterior displacement of atlas. The alar ligament restrains rotation of the upper cervical spine. Ligament biomechanics. The alar ligament, the blue one, 4, had an in vitro strength of 200 Newton, while the transverse ligament had an in vitro strength of 350 Newton. Clinical evidence that broken odontoid process suggests that the transverse ligament is strong enough to withstand physiologic loads. The alar ligament, on the other hand, due to its lower strength and its axial direction of loading, might be prone to injury and therefore require stabilization of the appropriate vertebrae more often than normally is assumed. The vertebral artery, it's important. Any spine surgeon, all spine surgeons should know about the anatomy of the vertebral artery. It branches from the subclavian artery. It ascends through the foramina of the transverse processes, starts at C6, sometimes C7, grooves the upper surface of the posterior arch of the atlas and enters the vertebral canal. Classification of C1, C2 instability. Fielding and Hawkins has classified this type of injury into 4 types. As you see in the diagram, type 1, unilateral facet subluxation with intact transverse ligament. Type 2, unilateral facet subluxation with atlantodental interval 3 to 5 millimeter and transverse ligament injury. Type 3 is bilateral anterior facet dislocation with atlantodental interval more than 5 millimeter. Type 4 is the posterior displacement of atlas associated with fracture of dens. This is the lateral inclination angle of C1. Actually, you don't see it in acute trauma, either in chronic diseases, like we mentioned before, or in neglected diseases. It's important to keep in mind, it depends, these 3 grades, on facet deformity, like in type 3, you see facet deformity, like the arrow is pointing, and the inclination angle, lateral inclination angle, which is the transverse axis of C1 on C2. It's more than 20 degrees. This is highly unstable. Clinical presentation. Patient comes to you with a cock-robin head position, rotation, and contralateral tilt of the head. Neck pain increases with the attempt of passive correction, headache, weakness and numbness with pyramidal signs, sphincteric disturbances, lower cranial nerve dysfunction, and respiratory distress. Myelopathy, respiratory failure, vertebral artery dissection, neurologic compromise, and rarely quadriplegia or death if left untreated. Diagnostic imaging. An X-ray, which is important, the anteroposterior open mouth view, you will see an asymmetrical distance between the lateral mass and the dens, like the yellow arrows in the lower X-ray show. This is the lateral X-ray, neutral, extension, flexion. It's difficult in acute trauma because of pain, but if you can get them, it shows an important thing. X-ray shows the atlantodental interval, which is the dark arrow, and the space available for spinal cord posteriorly, which is the yellow arrow. The atlantodental interval should not exceed 3 mm in adult, and the space available for cord or for spinal cord should not less be than 14. As you see in this X-ray, the one on the right, the readings, the spinal cord space, or the space available for spinal cord, is 11.9 mm, which is very low. This patient has a risk of paralysis. CT scan. This is the gold standard in diagnosis of C1, C2 instability. You have coronal, sagittal, transverse cuts, and 3D reconstruction. All are important. This is the CT coronal cut. It shows a symmetrical distance between dense and lateral mass, like the yellow arrow pointing. This is a transverse cut showing atlantodental interval, which is normally 3 mm in adult. As you see here, it's more than 3. It's almost 6. Also, the lower CT transverse cuts show you the rotational angle of C1, C2, which is normally 26.5 plus or minus 7 degrees. How you calculate this rotational angle? You get the transverse axis, the longitudinal axis of C2 to the median plane, which is 40 degrees, and the longitudinal axis of C1 to the median plane, which is 85. Subtract both, it's 45. By all means, it should not be more than 34 or 35 degrees. This patient is 45. Sagittal cut and 3D reconstruction. It shows atlantodental interval more than 3 mm in sagittal cuts, the yellow arrow. The blue arrow shows the 3D C1, C2 rotation and angulation. This is another 3D reconstruction CT. The yellow arrow is pointing to the facet subluxation. MRI. MRI is also important to assess the neural tissue. And we can get a lot of findings like atlantodental interval more than 3 mm, the yellow arrow. The black arrow posteriorly shows widening of C1, C2 posterior element. This means the posterior element or the posterior ligaments are torn. Also, this is a coronal cut on MRI. It shows asymmetrical distance between the dens and the lateral mass, the yellow arrow. The blue one shows disruption of alar ligaments. It's difficult, but if you can see it, if you know where to look, you can find it. This is a transverse ligament injury in a transverse cut MRI. The blue and yellow arrows are pointing. Management. How to manage such cases? Non-operative first. Indication, conscious, alert, and cooperative patients is important. Neurologically intact, of course. Atlantodental interval 3 mm, not more. Intact alar and transverse ligaments. Intact posterior ligamentous complex. The types you can get collar, Philadelphia or rigid collar Duchenne piece, non-steroidal anti-inflammatories, exercise programs, follow-up X-ray every week for 6 weeks, close to a major hospital in case any neurological deterioration occurs. The surgical management. Indication for surgery, atlantodental interval more than 3 or more than 5 mm, dynamic CT or X-ray with canal diameter less than 14 mm, rotation of C1 on C2 more than 35 degrees, neurological deterioration, associated fracture of dense, posterior dislocation, failure of conservative treatment. Wang has classified system of atlantoaxial dislocation. He has shown four classifications or four subclassifications of Wang. In type 1, there is instability. It's reducible in dynamic X-ray. So you do posterior fusion procedure only. Type 2, it's reducible with skeletal traction under general anesthesia, posterior fusion procedure. Type 3, irreducible with skeletal traction under general anesthesia. You have to go transoral to release anteriorly first before posterior fusion. Type 4 is a bony dislocation with bony anomalies, which is visualized by CT scan. You have to do transoral odontoidectomy and anterior fusion. Now we're going to explain the surgeries, the posterior C1, C2 fusion. This is Magrel technique. It's a transarticular screw fixation with sublaminar wiring. Both transarticular screw is a Magrel technique and sublaminar wiring is Magrel technique. Okay, this for stability, it's very high fusion rates, up to 100%, due to direct fusion instability, the most stable. Complication, risk of damage to vertebral artery, hypoglossal nerve, most difficult posterior procedure in all spine surgeries. Screw placement requires steep angle and joint exposure that can cause C2, C3 instability. This X-ray of a patient that I operated upon 3 months ago. He's well and fine, thank God. This is the second surgery you can apply. This is C1 lateral mass and C2 pedicle screw. This is called Harm's technique. More stable than intact spine on axial rotation, lateral bending, and translation. Less stable on flexion and extension. Actually, it is for in situ stabilization. Complication is extension of surgical scar to occiput, C2 root injury, vertebral artery injury, excessive C1, C2 venous plexus bleeding, you might get. This is another way, but it's a weaker way. This is C1 lateral mass and C2 laminar screw. You apply the C2 in the lamina. It's not as stiff as transarticular screw or the C1, C2 posterior spinal fusion. Okay, especially on lateral bending. Weaker in extension to occiput and early hardware failure. This is a modification of Magrel. It's a transarticular screw fixation with C1 hook. It's more stable compared to the transarticular screw fixation with lower risk of neurological damage, no wires, no sublaminar wires you have to apply. This is a posterior C1, C2 fusion, hard shell U-shaped rod, and Songer sublaminar wires. Now, the sublaminar wires are replaced with screws to the skull, to the base of the skull, and hooks or screws to the lateral mass. Okay? It's mostly used when you have an occiput fracture, occipital condylar fractures with a C1, C2 instability. This is just to complete the picture. This is not a case of acute trauma in a child. This is a case of Down syndrome. Okay, but it's here to present the anterior odontoidectomy and anterior fusion. It's difficult with higher risk of infection. The highest risk of infection is this approach and metal failure. Thank you. I hope you have enjoyed the lecture. Dr. Azzat?
Thank you very much, Dr. Muhammad Ablas, for this very valuable and nice presentation. We hope that all of us get benefit from your presentation. Now, just excuse me, I will not permit for questions unless at the end of the webinar, after the end of the 3 presentations. So now let us start with Dr. Dr. Ahmed Abdelati is orthopedic consultant in the spine unit of orthopedic department of SGH Medina. He is also one of the pioneers in spine surgery. He is lecturer of orthopedic in National University Egypt. So please let's enjoy his presentation. Go, Dr. Ahmed, please.
Thank you, Dr. Izzat. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank you all for the attendance. This is Dr. Ahmed Ibrahim. I'm an orthopedic surgeon consultant and spine surgery in SCGH Medina and a lecturer of orthopedic surgery in South Carolina University in Egypt. Today we are going to, inshallah, a little talk about the cervical facet dislocations and fracture dislocation. And excuse me for the PowerPoint was not working, so I would like to, the presentation will be in such way. As for the introduction, the spectrum, the fracture or cervical facet dislocation and fracture dislocation constitutes a spectrum of osteoligamentous pathology that includes the following: unilateral facet dislocation, which is most frequent missed cervical spine injuries on plain X-rays. It leads to for about 25% subluxations on X-rays and is often associated with mono radiculopathy that improves with traction. The bilateral facet dislocation, which accounts for 50% of the subluxations on the X-rays, it's often associated with the significant spinal cord injury. And finally, the facet fracture, which usually involves the superior facet of the cervical spine, whether it's unilateral or bilateral. 75% of all facet dislocations occur within the subaxial spine. That means from the C3 to C7. 17% of all injuries are fractures of C7 or dislocation of the C7-T1 junction. And this reinforces the need to obtain radiographic visualization of the cervicothoracic junction. The mechanism of injury is it's a flexion distraction force plus or minus an element of rotation. As for the classification, two types of classification: the descriptive one, which is widely used in the clinical setting. It comprises the compression fracture, the perist fracture, flexion distraction injury, facet dislocation, whether unilateral or bilateral, and facet fracture. The second one is the Allen-Ferguson classification of the subaxial cervical spine injuries, which is used typically for the researchers and not in the clinical settings. It's based solely on the static radiographs and mechanism of injury. Type 1 from it, the flexion compression, as you can see in the diagram, or vertical compression. The flexion distraction injury, which is similar to the chance fracture in the dorsal spine, in fact, which can be subdivided into 4 stages. Stage 1 is the facet subluxation, or stage 2, the unilateral facet dislocation. Stage 3, the bilateral facet dislocation with 50% displacement. And stage 4 is the complete dislocation on 100% displacement. Then comes the extension compression type. And here is the extension distraction type. And finally, the lateral flexion type. The clinical presentation, always the patient comes with whether a monoradiculopathy. He comes with monoradiculopathy, which is seen in the patient with unilateral dislocations, most commonly in the C5-6 unilateral dislocations, presenting a C6 radiculopathy, weakness in the wrist extension, numbness and tingling in the thumb. Or a C6-7 unilateral dislocation, which presents with a C7 radiculopathy, which can manifest in the form of weakness of the triceps, wrist flexion, and numbness in the index and middle finger. Or the patient can present with a spinal cord injury symptoms, which is seen in the bilateral facet dislocations. The symptoms always worsen with the increasing the subluxation. Imaging. As for the imaging, it includes the radiographs, the CTs, and the MRI. The plain radiographs, mainly the lateral views, always shows the subluxation of the vertebral bodies. Unilateral dislocations, as I said, leads to 25%, comprises the 25% of subluxations. and bilateral facet dislocations for about 50% of subluxations in the X-rays. One of the signs you can see in the plain X-rays is the loss of the disc height, which might indicate retropulsed fragment disc material in the canal, and this also requires an MRI later on. The CT scan, which is essential for the demonstration of the bony anatomy of the injury, malalignment or subluxation of the facet fractures, and associated fractures of the pedicle or the lamina. The MRI is the indications of the MRI are controversial, including the acute facet dislocation in patients with altered mental status, failed closed reduction, and or before open reduction to look for disc herniation. Any neurological deterioration is seen during a closed reduction. The timing of the MRI depends on the severity and progression of the neurologic event. An MRI should always be performed prior to the open reduction or surgical stabilization. It's mandatory, in fact. If a disc herniation is present with compression on the spinal cord, then you must go anterior. I mean the anterior decompression and through an anterior approach and the anterior cervical discectomy. The MRI is valuable here in demonstrating, as I said, in the disc herniation, the extent of the posterior ligamentous complex injury and the spinal cord injury or myelomalacia. This is an MRI showing bilateral facet dislocation from C5-6, as you can see. Treatment always comprises non-operative treatment or the operative treatment. The non-operative treatment in the form of cervical orthosis, external immobilization for 6 to 12 weeks. This is indicated in the facet fractures without significant subluxation, dislocations, or kyphosis. Instability with flexion and extension radiographs must be ruled out first. You cannot go for a non-operative or a conservative management unless you rule out an element of instability in the flexion and extension radiographs. The operative management or treatment includes the immediate closed reduction, then the MRI and surgical stabilization. The indications include the bilateral facet dislocation with deficit in awake and cooperative patient. This is very important that you must be sure that the patient is fully conscious and cooperative. You cannot do a closed reduction for a cervical spine unless the patient is awake and cooperative. Unilateral facet dislocation with deficits in awake and cooperative patients. The technique: never perform closed reduction in patients with mental status changes. The surgical stabilization follows the successful closed reduction. Unilateral dislocations are more difficult to reduce but are more stable after the reduction. On the contrary, the bilateral dislocations are easier to reduce but less stable following the reduction. Always obtain an MRI prior to surgical stabilization. The anterior or ACDF or the anterior cervical decompression and fixation can be performed in the absence or presence of significant disc herniation. As for the outcomes, 26% of patients will fail closed reduction and requires open reduction. And this mainly occurs in the patients with bilateral facet dislocation, in fact. So an immediate MRI, the open reduction and surgical stabilization, as I said before, anterior, especially if there is a disc material anterior, you must go anterior, then you can go for the posterior decompression and fixation. If disc herniation with the presence of spinal cord compression, then you must, as I said, go anterior approach and do discectomy. The technique for the closed reduction, it needs sufficient anesthesia, sedation, supervision of the respiratory function, and serial cross-table lateral X-rays. The technique: we gradually increase the axial traction with the addition of weights. A component of cervical flexion can facilitate the reduction. Perform serial neurologic examination and plain radiographs after the addition of each weight. When you must report if the neurological status of the patient is worsening and obtain an immediate MRI. The anterior open reduction It's indicated in the facet dislocations reduced through closed methods with an MRI showing cervical disc herniation with significant compression on the spinal cord. Anterior open reduction techniques can be used to reduce a unilateral facet dislocation alone. Reduction techniques involving distraction in vertebral bodies with Casper pins, then rotating the proximal pins toward the side of the dislocation. It's not effective for reducing bilateral facet dislocation. In fact, bilateral facet dislocations are reduced posteriorly. The posterior reduction in ability to the indications in ability to reduce by closed method or through anterior approach. No anterior compression of the spinal cord, no disc herniation. The technique we performed with lateral mass screws and usually have to fuse two levels due to inadequate lateral mass purchase at the level of the dislocation. And finally, the combined anterior and decompression and posterior reduction and stabilization. The indications, they are indicated when the disc herniation presents that requires decompression in patients that cannot be reduced through a closed or open anterior technique. You go first anterior, performing discectomy, position the plate, and then fix the plate to the superior vertebral body. By this way, the plate will prevent the graft from kicking out and still allows the rotation to facilitate the reduction from the posterior approach. And this technique also eliminates the need for secondary anterior procedure. The summary. Adequate preoperative evaluation of cervical facet fractures and fracture dislocation is mandatory. Thorough understanding of biomechanics, clarity of images, mechanism of injury are the grounds for non-operative versus surgical treatments. Neurological deficits call for urgent decompression and fixation. The patient assessment, including the mental status and MRI disc herniation findings, is fundamental in choosing the treatment options for the cervical facet injuries. Acute post-traumatic disc herniation with facet dislocation is an absolute indication for prior anterior cervical approach. Thank you all.
Dr. Habas, kindly introduce Dr. Ahmed Turki.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Sorry, Dr. Izzat have a problem with his internet. Now I'm going to introduce our friend, Dr. Ahmed Turki. He's a specialist in orthopedic and spine surgeries also. His lecture would be about the lower cervical fractures. Dr. Ahmed, are you here, sir?
Thank you, Dr. Muhammad. Yes. Welcome to everybody. Today, I am Dr. Ahmed Turki, Orthopedic and Spine Surgery Department in Saudi General Hospital, Medina. Today, we are going to discuss subaxial cervical vertebral body fractures, diagnosis, and management.
Dr. Ahmed, kindly go to data show mode. Yeah, thank you.
Yes, Mr. Allah, thank you. Regarding the anatomy of subaxial cervical spine, it includes the cervical vertebrae from C3 to C7. Range of motion, we have to know that majority of cervical flexion included in this segment of cervical spine, plus lateral bending and approximately around 50% of rotation. Regarding the biomechanics of the segment of cervical spine, according to Dennis, it includes 3 columns of Dennis: anterior, middle, and posterior. Anterior column includes anterior longitudinal ligament, as we can see, anterior 2/3 of body and disc. Middle column include posterior 1/3 of body and disc plus posterior longitudinal ligaments. Posterior column include pedicle, lamina, facet, transverse process, spinous process, interspinous ligament, and ligamentum flavum. Cervical spine injuries is a common cause of disability. Incidence: spine fracture without cord injury account for around 3%. Cord injury without fracture account for 0.7%. Most commonly involve C5 and C6 levels. Primarily involve adolescents and young adults, with a male predominance. Most common causes are RTA, fall, penetrating injuries, and sports. In the assessment of cervical spine, we have to go first for ABC, include head immobilization. Clinical assessment features include pain or tenderness, deformity or step-off, edema or ecchymosis, head position or abnormal tilt, plus neurological examination for suspected radiculopathy or myelopathy, either complete or incomplete cord injuries. After that, we are going to discuss the imaging of cervical spine, lateral cervical spine X-ray to include the junction area between C7 and T1, CT also for assessment of bony injury in details, MRI to determine if posterior ligament complex injury or disc involvement. We have many classification systems for subaxial cervical vertebral body fractures, includes Allen and Ferguson classification, flexion, compression, vertical compression, flexion distraction, extension compression, extension flexion, and lateral flexion. But this classification system is typically used for research, not for clinical setting. Another classification system used most commonly in the clinical setting is radiographic descriptive classification. It includes compression fracture, burst fracture, flexion teardrop fracture, hyperextension teardrop avulsion fracture, and facet dislocation. Facet dislocation point discussed in details with my colleague Dr. Ahmed Abdelati before. Regarding the compression fracture, it's a failure of anterior vertebral body without disruption of posterior cortex or retrobulge. Regarding burst fracture, is a fracture extension through posterior cortex with retrobulge in the canal. And this fracture is often associated with complete or incomplete cord injury. Flexion teardrop fracture. The mechanism of injury is a flexion compression injury. This fracture is a fracture of anterior inferior lip of vertebral body with retrobulge of rest of vertebral body into the canal. So it's often associated also with a spinal cord injury. Hyperextension teardrop fracture. We have here a small fleck of bone avulsed from anterior end plate of vertebral body, but without retrobulge. And this differentiates this type of fracture from the teardrop fracture, flexion teardrop fracture. It's a true teardrop. We are going now for treatments. We have conservative treatment and operative treatments. When to apply the conservative treatments? In a mild compression fracture and in a stable hyperextension teardrop fracture. This can be with rigid cervical collar or halo vest for 6 to 12 weeks. When to do surgical treatments? In a burst fracture, flexion teardrop fracture, and significant compression fracture with more than 11 degrees angulation or more than 25% loss of height. Our goals for surgical treatment includes stabilization of vertebral body, of vertebral spine, and to restore or improve sagittal balance, to decompress progressive neurological deficits, and to protect an intact or completely injured or incompletely injured neural elements. Regarding the guidelines of operative treatment, we have anterior approach and posterior approach. The indication for anterior approach are burst fracture with a spinal cord injury, disc involvement, significant compression of an anterior column, flexion teardrop fracture. This can be treated most commonly with corpectomy, strut grafting, or expandable cage together with rigid plate fixation. Regarding posterior approach, indications are patient is osteopenic, posterior ligamentous injury, lateral mass fracture, and dislocations. Treated with pedicle or lateral mass screws and fusion, but occasionally you need to do circumferential fixation. In a study done in 2003, This is a randomized prospective study for spinal cord injured patients together with subaxial vertebral body fractures. They concluded that anterior discectomy, corpectomy, and plate fixation, as well as a posterior fusion, are safe and effective in treatment of such types of subaxial cervical body fractures. Thank you.
Thank you, Dr. Ahmed.
Thank you, Dr. Ahmed Turki. Now for the questions. I'm Dr. Hablas with you again. There is Dr. Ahmed Turki, would you please stop sharing? Thank you, sir. Well, I have some of the questions here. There's one question about which the best for C1, C2 diagnosis. Of course, is the CT. I know you can get a lot from an X-ray, but it's difficult to take a good X-ray when the patient is in pain, when the patient is intubated, the patient is uncooperative, whatever the cause. The patient is vegetative and is intubated in an ICU. A lot can happen in C1, C2. But the best, the gold standard is the CT. With all the cuts, the transverse, the coronal, the sagittal, it's important. You have to measure the atlantodental interval, the rotational angle, the canal for the space available for cord. Okay, you can anticipate the alar and the transverse, especially the transverse ligament injury. You can also see the fracture of C1, fracture of dens, fracture of C2. The best is CT. The other question is about what would you prefer or the best surgery for C1 and C2 surgery. Okay, the best surgery, the one I actually performed before, it was the Magritte technique. I learned the Magritte technique, the transarticular screw, and the sublaminar wire. But with the new technique, I hope to use the transarticular screw with hook and C1. It's not always easy to apply a C1, C2 sublaminar wiring or hook, because most of the cases, or a lot of cases, you can find C1 posterior arch is fractured, and you have to depend only on the transarticular screw. But the transarticular screw has been good to me. It's difficult, I know, but I learned it well, alhamdulillah, and I'm using it. It gives me the best. It reduces, it holds the reduction. The Harms technique is just an in situ stabilization. It does not maintain the reduction because you see pedicular screws and the cervical spine are very weak. The cervical spine itself is very weak, but the transarticular screw, the Magritte technique, has done me. Dr. Azat is here or not, sir? Dr. Ala?
Yes, Doctor.
Okay. So I have, there is other questions like for Dr. Ahmed Ibrahim. If Dr. Azad did not join us again, there is a question for, yes, there is a question for Dr. Ahmed Ibrahim. Is there a rule for steroid or dexamethasone IV administration in cervical injuries? Dr. Ahmed Abdelatif.
Yes, Dr. Muhammad.
Did you hear my question, sir?
Yes, sir.
One of our colleagues have asked this question about the rule of steroids or dexamethasone administration in cervical injuries.
Yes, sir. As for the current literature, there is no supported evidence recently for the benefits of, in fact, for the benefits of steroid injection in cervical spine injuries, in fact. And this is including the steroids in general or the no benefits regarding
Solumedrol.
Yes, solumedrol or something or such medications. In fact, their complications or the impact or the harmful impact on the patient is much more than the benefit for the injury.
There was a rule about solimidrol injection in case of neurological insult with a loading dose, titration dose for 24 hours, and even some studies have reached up to 48 hours. What do you think about these papers, sir?
Yes, sir. In the, I think it's historical somehow. In the past time, there was a trend or just a rule for the cervical patient, Dr. Muhammad, as you said, as for the initial bolus, then the loading doses, and this was.
I myself still use them, sir.
And we find so much benefit, in fact. This is.
But you just said it's not supportive. You see, I know it's not supportive after 48 hours.
Yes.
Most of the papers has said that it's the same results as 48. Some even said that after 24 hours, even you have to start in like half an hour or 4 hours. The papers
yes,
had to think about that, sir.
The study, the only study which was done recently, I think it's for about 8 hours from during the first 8 hours of the trauma. They
Yes,
find some sort of benefits. In fact, recent literature said something like you cannot, or the complications of such steroids you are giving is much more harmful than the benefits you are gaining for the cervical. There is no rule, in fact, in the recent literature. But in the past, no one can deny there was too many cases that improved on such, or even the deterioration was controlled a little bit. This is for true, Dr. Mohammed.
Okay. There is another question, Dr. Ahmed, mentioned here from our friend, doctor. He says about the treatment of cervical bilateral facet dislocation. Would you prefer to go posterior, then anterior, then again posterior, or from the start go anterior, then posterior?
Yes, sir. This all depends on the MRI of the patient, whether the patient has a disc material which is compressing the neural tissue anterior or not. But the golden rule for such, you must go anterior prior to going posterior. You must go and do the discectomy.
When the patient have a neurology or not?
Yes, it's whether the patient having neurology or not, because sooner or later, if the patient is not in a neurological deterioration now, you must do the discectomy anterior so as not to deteriorate, or even so as not to happen from the early start. I mean that perhaps he has some sort of disc herniation without any deficit, you mean, but sooner or later he will have this deficit, especially if you go posterior from the first time. I mean that
according, I'm a little bit old. I use the old techniques that I go posterior first, do laminectomy, lateral mass screws without the rod. Then I go posterior, I remove the disc. It's very easy to do reduction of the facet, bilateral facet dislocation. Then you come back posterior, insert. After anterior, you have applied the cage and the plate. Then from posterior, you can apply the rod and close. I know it's a very long surgery. This is the old technique which all are doing.
So you prefer the reduction first, Dr. Mohammed? You're preferring, Dr. Mohammed, the reduction first, you mean?
Yes.
Before. Yes.
No, not the reduction, not the reduction. I'm just, because when you have a bilateral facet dislocation, if you have an intact lamina posteriorly, it would be anchoring the cords. The aim of posterior first is to do just simple laminectomy. But as you have done the laminectomy and opened already, you can apply the lateral screws, the lateral mass screws without the rod. So the vertebrae still be mobile for you to anteriorly to distract and remove the disc easily. So you can reduce the disc and apply the cage with the plate. Then go posterior, put your rod.
Posterior for the second time after the first time, you mean, Dr. Mohammed, صح?
Yes. That's what I do. I go posterior, I do laminectomy, the lateral mass screws. Then I go anterior, remove the disc, put cage and the anterior plate, then posterior with the rod. I know it's a very long surgery. It's like 6 to 7 hours. Positioning a patient with fractured cervical spine anesthetized. I know it's very difficult. But actually what I do.
This is kind of not an old school, Dr. Mohammed. It's some sort of it's a method. One of the methods you can try, which you find it much
well,
more
next time I'm sure we are going to try your method, inshallah.
productive, inshallah.
And I hope you assist us and help us in this surgery.
Thanks,
Okay.
Dr. Muhammad. Thanks.
Anytime, sir. Dr. Turki, are you there, sir?
Yes, Dr. Muhammad.
So there is a question from one of our friends. Is MRI is important in lower fracture cervical spine?
Yes, Dr. Muhammad, actually, we are doing MRI for the patient of subaxial cervical vertebral body fractures as a routine, together with cervical spine X-ray and CT. Why? To detect if we have a discus involvement or we have posterior ligamentous complex injury. Why also? Because this will judge our treatment plan, either to go for anterior approach or posterior approach. If we have disc space involvements, so to sure you are going first to do anterior approach to remove the disc. Or you have a posterior ligamentous complex, I think you have to add a posterior approach to add some fixation for the patient, extra fixation. So we are doing it as a routine.
Okay. There is another question, Dr. Turki. It's about
Yes.
to go anterior first or posterior first. Which you prefer? Which is the best? What the books say?
Yes, Dr.
The
Muhammad.
doctors answer this question.
Yes, Dr. Muhammad, thank you. Actually, Dr. Muhammad, this surgery for subaxial cervical vertebral body fractures basically is an anterior surgery. Anterior surgery allow you to remove the disc, allow you to remove the body that compromising the neurological elements. And also at that time, you can do also a rigid fixation. But in special circumstances, you have to go for posterior fixation also. Posterior fixation indicated in an osteopenic patients, we said before has posterior ligamentous complex injury. If we have added lateral mass fixation, lateral masses fractures, or we have dislocations. So at that time, we are doing anterior and posterior. Occasionally, you are doing both to gain around 360 degrees of circumferential fixation for the patient. Actually, it's an absolute anterior approach, but sometimes we have to add a posterior approach also.
Well, thank you, Mr. Dr. Ahmed Turki.
There is
another question for me, which is about if you have a fracture dense or fracture of the odontoid process, what would you do? Actually, I haven't seen a rotational instability with odontoid fracture. Most of the odontoid fractures I've seen, like they were type 2, they were mostly stable, not even reversed obliquity, alhamdulillah. I have seen one. I have operated upon using the anterior odontoid screw, and another case I used the hollow vest. I know that the hollow vest is much better, safer, not better, it's safer. The odontoid screw is more difficult, need 2C arm to be available, which is we have in alhamdulillah. But the higher risk, the patient sometimes does not prefer, as you have to ask the patient, tell him about the complication, tell him about the options. Well, the two cases, alhamdulillah, united, thank God. But I didn't mention here, I only wanted to discuss about the rotational instability. There is another question for me about the hollow traction. Well, sir, our friend, the Indians, have published a paper about the skull traction for C1, C2 rotational instability. They use it in both acute and chronic. But they have strong hearts, actually the strongest heart ever. They have bulls, man. I'm sorry. They apply like 45 kilos to the head on a bohler traction or a skull traction, and they can charge the patient home, and follow up every 3 weeks. This is very difficult. I don't think the Saudi Commission, the MOH would ever apply or ever approve that. Set a patient with skull traction and 45 kilos hanging from his head to home. But it's written, have papers. If you want, you can contact me, and I'll be gladly to send it to you. About the
it's a weight of an adult, Dr. Muhammad. The patient is applying a weight of an adult man.
Yes, sir.
it's very difficult.
They are saying don't go more than 45.
Yes.
45. Like you can get the hit from the floor. I don't think I even did not mention it in my conservative treatment.
Yes.
I think it's more aggressive technique. I think posterior surgery is safe, much safer than the heart traction.
And even the outcome, Dr. Mohammed.
Yes. The patient can move easily, early.
Yes.
Alhamdulillah, none of the patients I have operated won't have any post-operative neurological deterioration. Thank God. And with the good equipment available in our hospital, in the Saudi German hospital in Medina, we can do most of the surgeries, alhamdulillah. That's it. I don't see any more questions.
So we finish our webinar.
No, and most of the question about the same two first questions about which is the best diagnosis, which is the best to operate, which the best to use. That's it. Thank you all for listening. Dr. Ab, do you have anything to add?
Dr. Muhammad, do you hear me?
Dr. Azzat, welcome, sir. Back.
Thank you very much. Do you hear me? There is a question for Dr. Ahmed. Can you check? There is a question for Dr. Ahmed Turki.
Yes, Doctor. Tfadal, Doctor.
There is a question for Dr. Ahmed Turki. Do you hear me?
Yes,
Dr. Azzat. Disruption.
Yes, Dr. Azzat. Yes.
This question, do you prefer strap grafting or case in your fixation?
Yes. Actually, we are doing regarding we are doing as a routinely expandable cages. Why? Because the strap grafting has added a morbidity for the donor side, lengthen our operation time, and by these expandable cages, we are abolish this complication with good results. So routine, you are doing expandable cages plus anterior blade fixation.
Can I say something, Dr. Turki, about the expandable cage?
Yes, Dr. Muhammad, sure.
I know the expandable cage have saved us a lot of time, despite the old pyramesh that you had to cut the same size, and after you cut a lot of it, if you just 3 millimeters less, it's not stable and you have to do it again. I know that, but the expandable cage has a problem, that there is a part, when you expand, there is a part of the machine or the cage, this cage, you cannot apply graft in it. Also, the remaining part of the cage has a large holes. Even if you try to apply graft in these holes, okay, it fell down. Not like the pyramesh, the old corpectomy cage we used to apply. What's your opinion about that? I know that the X-ray you have shown, has a pyramesh, right?
Yes, Dr. Muhammad, completely you are right. We are relying regarding the fusion, we are relying on the posterior fusion, not the anterior fusion and presence of expandable cages. Yes, as you told, this expandable cage allow you to do to maintain the cervical lordosis, shorten your time, your operation time, but the problem is the fusion, because minimum amount of the graft inside the expandable cages is allowed. So we are relying on at that time the posterior fusion.
Not the oncovertebral joint. You are not allowed. You're not contributing.
Yes, completely right. Plus the oncovertebral joints.
Yes.
So it's a circumferential fusion.
Yes.
Okay.
360 degree fusion. Yes.
Well done, sir.
Thank you.
Any more questions?
There is no more questions.
Okay, Dr. Azzat, thank you a lot. So we reach our end of this webinar. Thank you all attendees for attending our webinar today, and a big thanks to our eminent doctor in orthopedic department, that we are as a GH family proud to have them in our hospital. Dr. Izzat, Dr. Ahmed Turki, Dr. Ahmed Ibrahim, and of course Dr. Ahmed Hablas. Thank you a lot. أفدتم وأبدعتم. جزاكم الله خير وجعل